today we'll be having a discussion on hysterosalpingography, that is HSG, which is an important MRCPI OSCE exam station. So do like, share, and subscribe Study Medic, and also press the bell button icon to get the updates on the recently added videos. So do remember that success is a journey and it's not a destination. So here for this will be a structured discussion about HSG with the examiner, and the examiner will be having a series of questions. So we'll be discussing the questions like how to read the HSG film and how you will explain the woman about the procedure and the complications and reports, and what are the different causes of tubal block, and what are the different ways of checking the tubal patency, and what are the benefits and the limitations, and what are the indications of tubal patency testing. So coming to HSG, so what is an HSG? So it is a radiographic evaluation of the uterine cavity and the fallopian tubes. Okay, so it is an X-ray examination which is usually done a dye is injected, a contrast is injected, and then it is the study to look for the uterine and also the fallopian tube anatomy. So here the dye is injected into the contrast is injected into the cervical canal, and then a X-ray is performed. So when can the radiographs can be taken? So usually minimum 4 images are required. So usually it is taken at the beginning of the uterine cavity filling, and when the cavity is filled, then the third one is taken when the tube is filling, okay, at that time, and fourth is when there is spillage of the contrast into the peritoneal cavity. So this is HSG. So what are the indications of HSG? So HSG is used for a number of reasons, but the main indication for doing an HSG is for evaluation of tubal infertility. So for whom, like cases of infertility, especially tubal infertility, if there is a suspicion, like if there is a history of chlamydial infection, or if there is history of a PID or endometriosis, which can cause adhesions and cause tubal block, or if there is a history of an extensive pelvic surgery, so where there is anticipation of adhesions, so that can lead to distortion of the tubal anatomy. Also, it is used to evaluate the uterine cavity anatomy also, and identify pathologies like the endometrial layer pathologies, especially the submucosal leiomyomas, the endometrial polyps, the synechia, and if there are any Mullerian anomalies, and also in cases of recurrent pregnancy loss. So main basic indications are for evaluation of infertility and recurrent pregnancy loss. So it is rarely performed, but also it is usually done to check if there is a patient has undergone sterilization, to check either tubal patency or reversal of sterilization. So for that it is used, but it was used before and it is rarely used nowadays. So HSG has a sensitivity of 76 to 96%. So what are the contraindications? So contraindications is having an allergy to the contrast as it is used. So that is a contraindication. Pregnancy itself is a contraindication for performing an HSG, which is these are the absolute contraindications, and for this reason, because we are using the radiation, that's why in pregnancy it is not indicated. So that's why the main it is usually performed in the follicular phase, like the first 12 days of the cycle, where the chance of having an pregnancy is low. And also if there is a case of active bleeding, in that case also it is not performed, and especially in cases of acute pelvic infection or an acute PID, these are the absolute contraindications where an HSG is usually contraindicated. So what are the different ways of checking the tubal patency? So here, as we know, it is an HSG which is usually done. So, and what is the difference between an HSG and a hysterosalpingo contrast ultrasonography is that HSG is the contrast is used, but the main imaging is by the X-ray. Here in hysterosalpingo contrast ultrasonography, again the contrast is used, but the imaging is done by the ultrasound. Okay, so that's why there is less chance of radiation in the case of hysterosalpingo contrast sonography. And also laparoscopy and dye test is used nowadays to check for the tubal patency. It has more benefits, like also to check see and treat at the same time, like diagnostic and also therapeutic if there are any adhesions, so that can be treated in case there are any peritoneal adhesions, so that can be treated. And also it carries a risk, like it has a risk of anesthesia, and also it cannot rule out the intrauterine anomalies as HSG does. So when is the procedure performed? So as I said, to avoid doing in pregnancy, so that's why it is usually performed in the follicular phase of the menstrual cycle, maximum 12 days from the last menstrual period, to avoid any false positive intrauterine filling defects, and also to avoid any proximal tubal occlusion also. And also some centers, they do perform a routine pregnancy test before doing the HSG. So what is the technique which is most important? So it is usually performed in the follicular phase. So proper informed written consent should be taken from the patient, showing that the risks and also the benefits of doing the procedure, the proper technique of the procedure, and what they can expect after the procedure. Okay, and what are the implications of the reports. And also the procedure will usually take 3 to 5 minutes. And how it is performed is, here the radio opaque contrast is usually inserted into the uterine cavity. Okay, and then the images are taken. So that is the main aim of this test. So here, where it is very important to do the technique very properly, because if it is done in a wrong way, then it can cause the discomfort, like it can cause pain, and also the image quality can be low, and it can also give a false positive diagnosis. So that's why an empty bladder also is beneficial, and it will decrease the discomfort from the speculum. So what should be done? So like before a pelvic examination should be done, patient's consent should be taken, bladder should be emptied, and also the patient should be draped properly, and the privacy should be maintained, and it is usually done in the presence of a chaperone. That is a must. And also the verbally the procedure should be explained to the patient. So these are the materials which are required for a HSG. So here usually the installation devices and instruments include a Cohen's uterine cannula or a 5-French catheter. Okay, and to retract the vaginal wall, a SIM speculum is usually preferred. That is a non-self-retaining speculum, and because it can be easily removed. So the patient will be placed in a dorsal lithotomy position, and then the speculum is the first step which is placed into the vagina to bring the cervix to the view. And then the cervix is held gently with the tenaculum, okay, to hold the cervix properly. And this is the Cohen's cannula. It comes in different sizes. So in nulliparous patients with a pinpoint or narrow acorn tip cannula can be used, and a wider cannula in multiparous patients can be used. And all air that is there in the cannula, that should be removed in the vertical position. So this is the cannula. Then here we gently give the traction on the cervix, so that the uterine body becomes perpendicular to the X-ray beam, and we get correctly desired images. Okay. So here, because it is very important to know correctly have the correct position of the uterus, because if we do not do so then it can lead to intrauterine filling defects, or it can miss that. And if there are any fundal contour abnormalities, that also it will be missed if it is not positioned correctly. Also, sometimes a uterine spasm can happen because of inserting of the cannula, and that's why the recommendation is to use the media which is warm to the body temperature and injected slowly, also to avoid vasovagal reactions. So then if a radiograph is taken after installation of the contrast, and as I said, there are 4 images minimum that should be taken at the beginning of the uterine cavity filling. And then when the cavity is filled, the uterine cavity is filled, to look for any contour abnormalities, to look for any uterine cavity filling defects. Then when the tube is filling, at that time image is taken to evaluate the tubal mucosa. And the final images, that is after when there is spillage of the contrast into the peritoneal cavity, then the images are taken to see if the tubes are blocked or not. And additional images may be taken depending upon the person who is doing. Okay, so the maximum radiation dose to penile gonads during HSG is 2.7 milligray. And the correct technique during the HSG not only improves the image quality but also decreases overall radiation exposure. So the correct the position, the less the radiation, and also improve the diagnosis. So that's why the positioning of the uterus is very important. So what can be the complications after having an HSG? So these are the frequent ones can be the mild abdominal cramping, which can be there due to injection of the contrast, and which can irritate the uterine muscle. Also there can be light spotting. Also sometimes there can be infection, especially in those who have any previous foci of infection. Also there can be risk of vasovagal reactions, especially when the cervix is held by the tenaculum. So and when the cannula is inserted through the cervix, in that time the vasovagal reactions can be there. So that's why we have to make sure that we insert the cannula very slowly and not with any undue force. Also if there is inserted the cannula is inserted very fast and inadvertently, so that can even lead to uterine perforation, and sometimes there can be intravasation of the contrast into the blood vessels, so which can cause reactions. So we have some cases of HSG. Okay, so this is the case 1, where the patient is has been had an HSG done for evaluation of infertility. So here we can see that the down we can see that it is the cervical canal followed by the broad arrow, which shows that the uterine cavity which is filled properly and there are no filling defects, and also the small arrows on both the sides, which show that there is proper spillage of the contrast in both the tubes, and hence this is a normal HSG. Now coming to the second case, so here again you can see that the cervix is normal and the uterus is showing the normal anatomy without any filling defects, and both the tubes, the right and the left tube, both the arrows, again the tubal anatomy we can see properly, and also we can see that there are the dark areas of the contrast materials which form at the end the triangular shape, the arrows, okay, which is fluid surrounded by the bowel loop. So even this is also a normal spillage of the contrast, and this is a normal HSG. Now coming to this HSG, so here the cervix and the uterine anatomy looks normal. There is no filling defect. On the right side, the arrow, you can see that there is you can see the anatomy of the fallopian tube, the spillage of the contrast on the right side. But on the left side, we are not able to see any fill of the contrast on the left side, and that indicates that the left tube is obstructed. That is, there is left tubal block. And here in this case, as we see that the uterus shape is seen correctly, and on the left side the contrast can be seen, delineating the proper left tube and also spillage of the contrast. But on the right side we are not able to see any spillage of the contrast, and this indicates that it is a right tubal block. So thank you guys for listening to the video, and yes, thank you so much.